Okay, I think we can get started. Welcome everyone to Geriatric Medicine Grand Rounds. I know a few more people will be joining us, but we'll go ahead and get started so our speaker has plenty of time. But I welcome all of you. We have a really great speaker today who will be familiar to many of you, for those of you who practice, particularly on the inpatient side at Harborview. Aspen LaRiviere is a nurse practitioner, and she's the Ortho Advanced Practitioner Lead, Advanced Practice Provider Lead for the orthopedic service, and has been really a great partner with many of us in caring for the older patients that we take care of at Harborview. And I am really excited to hear your perspective on the management of pelvic fractures in older adults, which can be a really functionally impairing and life-changing event. So I'm really grateful that you're taking the time out of your busy schedule to speak to all of us, and we're looking forward to learning from you this morning. So thank you, Aspen.
Yes, I'm very happy to be here. Happy to chat with everybody on this beautiful Friday morning. Like she said, my name's Aspen. I'm the nurse practitioner that is on the pelvis team specifically, but I'm also the lead of all the other ortho APPs, and there are 12 of us. And so what is spectacular about that is that we have APP coverage from 6 a.m. until 11 p.m. every day, Monday through Friday. And then on the weekends, we also have APP coverage. It's a little bit different dynamic, but we also have APPs on the weekend. And so there's a lot of us, so there's a lot of resources, a lot of people that we can work with and communicate with. I've been here at Harborview for almost 12 years. I did the first 8.5 on general surgery, and then I transitioned over to orthopedics about 3.5 years ago. And throughout this time, I've worked with orthopedic patients. As you guys know, ortho patients just don't go to ortho. They go to all the other teams, especially when it's polytrauma patients. And so I've been dealing with these types of patients for my entire career. My nursing background is all emergency medicine for the most part. And so I've really been dealing with orthopedics my entire career. I am dual certified in adult. I'm an adult nurse practitioner, but also an adult and geriatric acute care medicine. So I have worked with both populations. And a little bit, I also am a faculty clinical advisor in the UW acute care DNP track, and I'm also a guest lecturer for their program. So nice to meet you all. I'm going to share my screen here if I can figure out how to do it correctly. Let's see, I got to go here. Share screen. Can everybody see that?
Looks great.
Awesome. Okay. So there's my little introduction. So at Harborview, like I said, we have 12 APPs. I wanted to talk a little bit about the structure of the team because I think it really helps to facilitate communication if you kind of understand how things work and how people are assigned. We've got our main 3 trauma teams, which are red, blue, and green, and they alternate call. And so it's like red, blue, green, red, blue, green, red, blue, green. So when they come in, that's who determines who their primary orthopedic team is. And then if they have a pelvic fracture, they have a consulting, my team, which is pelvis. And pelvis is just a consulting team. We're not a primary team. We only manage consulting. And so that's why when you look at the chart, you'll see that there is a primary team, red, blue, green, and then there's also pelvis signed in. And so if there's a pelvis question, then you can message whoever signed in for pelvis. The caveat to that is that the APPs for pelvis are Monday through Friday until like I'm here Monday through Friday. But if it's like a nighttime question, the evening APPs will be signed in. If it's a nighttime question, then it'll be the orthopedic residents. But that's why when you look at the chart, sometimes it shows a primary ortho team and a pelvis team. Not specific to this lecture, but there's also a spine team, foot and ankle, hand, and there's APPs on all of those teams except for foot and ankle. Those are managed by fellows and residents. And hand is an interesting dynamic. It's a mix between ortho and plastics. And so we are not involved with the management of hand patients either. However, red, blue, green, spine, pelvis, that's all us. You can always talk to some of the APPs. Those different teams have clinics on different days. And so when we're trying to arrange follow-up, we try to group together as many orthopedic patient follow-ups as we can. But as you guys know, not everyone is in clinic every day. And so then it's hard to group together, especially if it was an operative patient as opposed to a non-operative patient. Then that operative attending wants to see that patient if able. And so red, blue, green are Tuesday, Wednesday, Thursday. And then there is a pelvis clinic on Monday. And then there's also an APP clinic on Friday where they can see pretty much anybody that needs like a wound check or just like a quick down and dirty check-in. And those are the times that we can arrange clinic follow-up just on Friday, and it doesn't have to be with the orthopedic surgeon like for the wound checks. So that's a little bit about how our teams are set up here at Harborview. We do have residents on all of our teams, the structures of everybody's teams. We have chief residents. We have R1s, R2s, some R3s and 4s mostly go to children's in their 3 and 4 year. But there's a lot of people involved in our team and a lot of people that are involved in the decision making. And so sometimes we don't have the answer that you need right then and there. We have to ask, and sometimes that person is scrubbed in. And so then we communicate down to the OR, or if it's not emergent, then we will go down to the or if it is emergent, we can go down to the OR, or if it's not emergent, we can wait until after they're done with the current case to get the answers. But we do have to work specifically with the chiefs, and as they're kind of like the decision making people when it comes to like weight bearing status and management, whether it's going to be operative or non-operative, and those types of decisions. So what we're talking about today, we're going to talk about pelvis fractures involving the acetabulum or the hip socket, pelvis fractures involving the pelvic ring, and pelvis fractures involving the sacrum. I'm not going to talk about the femur, the femoral head, or femoral neck, or hip replacements. A lot of people think when they say pelvis, you automatically go to, oh, I broke my hip, which turns out to be, femoral head, femoral neck, and then they get a hip replacement. But that is not what my talk is about. Those are managed in a completely different way. And there's a lot of really interesting statistics out there about those types of patients, but that I'm just not addressing that in my talk today. So when we're looking at the pelvis, good old Netter's anatomy, you can't go wrong. Just reviewing what we're talking about. You're talking about the pelvic ring here. You're talking about the acetabulums, the sacrum, the iliac wing. And when we order x-rays, when you have folks that have a pelvic ring injury, the x-rays you're going to get are going to be an AP pelvis, an inlet view, and an outlet view. If you have a patient who has an acetabular fracture, you're going to get an AP pelvis x-ray. Jude, also known as iliac oblique and obturator oblique, but Jude is just easier to say. So you'll get AP and Jude. If you have a combined fracture, like an acetabulum and a ring, then you'll get all 5 views. Can you guys see my cursor on my screen? What I'm pointing at?
Yes.
Excellent. Okay. So those aren't perfect they're textbook pictures, but they're not the perfect picture, but it gives you an idea of there's different angles that we can look at different things. So on the iliac oblique and the obturator oblique, what's important about this is that they can twist. You twist like the imaging. You don't have to twist the pelvis, but the way that you look at the angle of the acetabulum, you can look at the posterior wall and the anterior wall and look at those lines and how you can get your alignment with your hardware, or if you're looking at a non-op injury, it can be to help us determine if there's been any displacement after the patient is ambulated. And so that those Judet views are often the most common ones that get missed, and they're the most informational when it comes to acetabular fractures. So these are x-rays, but they're called ghost views, which can basically, we take a CAT scan and we get x-rays from ghost views, which is really part of some of the amazing technology that we have now. And you can see here on the left side of the screen, this is the acetabulum fracture here, and then how it was repaired. Just an example that there's a lot of hardware. There's a lot of, it's not just a simple surgery. It's a time consuming, long surgery, and that's part of the reason why these acetabular fractures that are managed operatively can be, pretty big surgeries. It's a lot of hardware, it's a lot of alignment, it's a lot of intraoperative imaging. When we take people to the OR, we do a little bit, we take a picture, we do a little bit, we take a picture. So if you go back and you look through PACS, you can actually see a really bad movie, so to speak, because you can just click through each part of the surgery and you can watch them, put the pin in, get the alignment, drill the hole, advance the screw over the pin. It's really fascinating, actually, when you think about everything that we can do technology wise and how we're able to get the best operative fixation in the operating room with the radiology working together. Again, good old Netter's anatomy. When we talk about the way that we define the fractures, there's a lot when we have acetabulums, there's a lot of different letters that you'll see in front of the type of fracture. And so those letters signify like your posterior column, your anterior column, whether it's a hemitransverse, a posterior, a transverse. And so when we're looking at our hip socket and then the iliac wing and how much is involved, knowing these different identifying kind of areas helps you a little bit understand more where the fracture pattern lies and how it's best going to be fixed operatively, because all of these injuries are not fixed the same. It depends on whether it's an anterior column or a posterior column, if they're going to do a posterior approach versus an anterior approach, whether the patient has to be prone or supine, or all the different things that go into making those decisions about operating really, really involves the area in which the fracture is involved. And now that we have this amazing technology about these 3D reconstructions, which I have a little bit later, there's another picture, a little bit more explanatory of the different types of fractures, but we have these 3D technology that we can take the pelvis, get a 3D reconstruction from the CAT scan, and we can spin it, and we can see, what different parts are available, what the different parts are fractured. And then also we can radiographically remove the femur. And so we can look at the acetabulum in the socket, and you can tell when you look at it how much it's involved, and look at the fracture pattern. There have been studies on these 3D reconstructive CTs, and patients have said that they understand their fractures so much more because they're able to visualize it. And I usually actually have a pelvic model that I'll go with and see my patients with and say, this is where your fracture is. And it's just that real life, people don't know how to read x-rays and they don't know how to read CAT scans, but when you have a 3D picture of what the pelvis looks like, and you can go over those imaging with the patient, it really helps them understand, why do I hurt here? Why do I hurt here? Why does my groin hurt when you told me that I broke my pelvis? So it is, the technological advances they're incredible. But here, so when you're looking at the fractures, like you can understand both columns, if it involves the posterior and the anterior column, if it's a hemitransverse, if it's both, if it goes all the way across. There's a lot of different descriptions when you talk about acetabular fractures. When we talk about managing these, now there's a few different ways to manage them. If we operate, kind of the two things, the way that we fix them is an open reduction internal fixation, or it's referred to as an ORIF, if you see that in the documentation. And then another way that we fix them is called a closed reduction percutaneous fixation or pinning. So you might say CRPP or CRPF. They're not any different. They mean the same thing. I think just people were taught differently. And so some people say percutaneous fixation and some people say percutaneous pinning. And I'll talk more in depth about the differences between those two. And then we can do an exam under anesthesia, which is where you go in and we can manipulate it and see if the fracture's unstable. And then there's non-operative management where we just let it heal on its own. And then we can also treat it with putting the patient in traction and keeping the traction in place for 6 to 12 weeks. So here's some of those 3D reconstructive imaging. And as you can see, this person's leg is radiographically removed. They have a leg. And I wanted to put a video in here, but I couldn't figure out how to do that. Maybe I need to learn that for the next presentation. But when you're able to rotate the CAT scan, you can see fractures here. Like when you're looking right here, you can't see that fracture when you're just looking straight on. So the ability to rotate and manipulate the images so that we can see all the different angles really can change our treatment plan dramatically. And they have access, they pull up these images in the OR, and they have the ability to look at CAT scans and plain films. So this is a non-displaced anterior column, posterior hemitransverse fracture, very common, AC, as you saw the abbreviation there, very common, lots of letters. And you can go back to these type of pictures if you're looking at those letters, like if you're looking in documentation, and you can go, okay, so it's a posterior wall, it's a transverse, hemitransverse, and then you can identify which fracture pattern that patient was operated on for. This is an example of how we fix the acetabulum. So this is plates and screws, and there's actually, it's kind of hard to see, but there's a little plate off the big plate. And so it stabilizes the fracture, and it allows for the patient to have some toe touch weight bearing post-operatively. And then you can see here also, you can see all the staples. It's a pretty big incision. It's not just one incision. It's not just one small incision. It's a quite involved incision, which goes along with post-operative pain and challenges in mobility with an abdominal incision and things like that. Probably the most common incision is your Coker-Langenbeck, because it is it's a very large incision, but it's the most common due to the type of fracture that we see. It's a posterior wall fracture, which is a lot of dislocations, posterior column, posterior wall fracture with transverse fracture. But this is a very large incision. This is a 4 to 6 hour case in the operating room, sometimes longer, depending on the patient's body habitus, because they have to get through all the gluteal muscles and they have to retract, these large muscles that are very hard to get through. And in addition to that, it's 40 to 60 staples, sometimes even more than 60. And these incisions they're quite long, as you can tell here. And they're painful. And when people come out of these operations, their buttocks are very sore because we've been retracting their gluteal muscles. And so it is, it's a pretty involved operation. Post-op with this type of incision, typically a patient is toe touch weight bearing Now the literature, I don't know, maybe in like the last 5 years has changed. What used to be, it used to be, what am I trying? Touchdown, like there's touchdown weight bearing, there's toe touch weight bearing, and then there's weight of leg, flat foot. All three of those things mean the same thing. But a lot of people were doing toe touch weight bearing, and they were showing that people were getting equinus deformities because they were pointing their toes so much because they were toe touching. And so people were not having, they were having issues with their Achilles. And now when we describe it better as weight of leg, flat foot, or touch down weight bearing, people weren't having those issues. And so they found that that's a better way to explain it to the patients so that they don't have any issues with their tendons after pointing their toe for, 6 weeks. The ilioinguinal approach is typically like, this is that approach that we saw in the x-ray that I showed you with the staples. This is typically it can be just one incision. They also can include it with the fan and steel. And it also is 20 to 40 staples. It's a pretty big incision. And this is an anterior approach can be another 4 to 6 hour case in the operating room, because there's there's not as much, big muscles, but there's more vasculature interiorly. And there's more things that they have to kind of work their way through to appropriately visualize the anatomy and get to the fracture. And so a lot of times, or sometimes, people combine this incision or a more, just the fan and steel incision combined with the Coker Langenbach. Also, if they have a front back, if they have an anterior wall and a posterior wall. And so that is even, 2 very long cases. Let me just check my notes. Yeah, it's the T-shaped fracture that typically require a combination of the 2 incisions, which is a pretty extensive surgery. This is your fan and steel, anterior transverse suprapubic. This is specific to anterior column, or if you have an anterior pubic symphysis injury or fracture. I say injury because you don't necessarily have to have a fracture. You can just have ligament compromise. And then we still have to stabilize that anterior pubic symphysis, which is interesting because we say it's a pelvic injury and people are like, well, I didn't break my pelvis. And it's like, no, but you did injure your ligaments that hold everything in place. And so that can be just as, when you hear the expression, a sprain's worse than a fracture, a sprain can take longer. And so when you're compromising ligaments, you still sometimes have to have hardware to stabilize everything to keep it in place while those ligaments heal. That's more APC injuries, and we'll get to that. But this is about 20 staples, and again, it can be about a 4 to 6 hour case. Postoperatively, people come out of the operating room. They typically have a couple drains. I see a couple of things in the chat. I'm just going to check real quick. Okay, thank you. Okay, sorry about that. Anyway, postoperatively, likely the patient will have 1 to 2 hemovacs and sometimes an incisional vac. An incisional vac is very attending specific. I have 4 attendings, and 2 attendings love incisional vacs. 1 attending will absolutely never use an incisional vac. And the 4th attending is kind of like, well, it depends. I'll use it on the Coker Langenbach, but I don't really want to use it on the ilioinguinal approach. So it depends on kind of what they want to do. But a hemovac, they just put in the, in the deep tissue and the superficial tissue to make sure that if there's any, residual bleeding or fluid collection, that we can evacuate that instead of having any retained hematomas. And then the incisional vac is a negative pressure system that increases healing over the incision, but also decreases seroma formation underneath the incision. And so The incisional vac stays on for 7 days. We have a couple different types. One is silver impregnated, one is not, depending on what sponge you pick. But the incisional vac can stay on for 7 days, and the patients can leave the hospital with them. It's not something that has to stay on, has to keep them in the hospital, which is really nice. With these 4 to 6 hour cases, there is often bleeding. We always prep blood prior to going to the operating room. And the drains will stay in for 2 to 4 days. If these patients need therapeutic anticoagulation post-op, we can restart it post-operatively. If it wasn't a super bloody case, we can start it like the day after surgery. And when we start it, we like to leave those drains in for until they're therapeutic on their anticoagulation, on their therapeutic anticoagulation. And so we leave those in, and then once they're kind of therapeutic for like a day, we make sure that the drain output is low, and then we take out the drains. The drains we like them to be less than 30 cc's for 2 consecutive shifts back to back. And so we're really trying to encourage the nurses to document I's and O's every 8 hours as opposed to just once a shift, because then that doesn't really give us good data of how much per shift to help us determine if it's time to remove the drains. Obviously, pain control is huge, and especially with our geriatric population, we got to be careful, as you guys know, with our pain medications. And so we really seek your guys' assistance, and we seek out, if necessary, the pain team, although it's not as common with our geriatric population, but, IV medications, and then eventually transition to PO. And, I am amazed sometimes these older folks that are like, I'm good, I'll just take Tylenol. And, my 35-year-old person with no coping skills is like, I need a PCA and ketamine and all of this. It's pretty incredible what some of our geriatric patients can handle. But so pain control is huge, because we have to be able to give them enough pain control so that they can mobilize. These are big surgeries, and we want people up and moving as soon as they can move. Drains do not keep them in bed. Vacs do not keep them in bed. Really, the only thing that keeps them in bed is traction, which we haven't gotten to. But we want people mobilizing as soon as they possibly can, and within their precautions. People are going to have precautions for typically 4 to 6 weeks. And then at the 6-week mark, we're going to get x-rays, and we're going to look at the hardware and make sure that nothing has moved, nothing has shifted, nothing has broken, and that we've got evidence of healing before we want to advance their weight bearing. So that's pretty, we don't get x-rays. A lot of people ask that question, when are the next x-rays? 6 weeks is when we get our first set of x-rays post-op. Obviously, we get x-rays intraoperatively, but post-operatively, 6 weeks. Everybody gets the 24 hours of perioperative antibiotics also. And like I said, we get PT and OT involved as soon as possible, because we want to get people up and moving, better for their lungs, better for their skin, better for their recovery, just better all in general. So that is the open reduction internal fixation route. If we go closed reduction percutaneous pinning or closed reduction percutaneous fixation, CRPP and CRPF, these are small incisions. These are shorter cases, and they are, the incisions have like 4 to 6 staples. If they go in from both sides, then they will have 4 to 6 staples on each side. If they go, like retrograde, then we'll have a glued incision on their buttock that we don't even need to put staples in. And so it's actually a really, I hate to use the word non-invasive, because I feel like any surgery that involves general surgery or general anesthesia is invasive, in my opinion, but it's a less invasive way of fixing these. And it's amazing that these people, they feel better. They just feel so much better. So we can do screws in the posterior column. We can do, posterior screws, posterior ring, anterior ring. There's so many things, and we can do them in combination with plates and screws also. If we do them in combination with plates and screws, then it's not just the small incision, but if it's just screws, it's a smaller incision, and people are up walking the night of surgery feeling fantastic. For any patient population that we opt for, whether they're ORIF or CRPP, we always do a wound check at 3 weeks. A lot of times we get questions inpatient, you know, can this person's leaving, can we take staples out early? And the question to that is always going to be I need to take a look at the patient, because if you have an incision that's this big and you want to take out staples a week early, 95% of the time we're going to say no, because typically they open up or they have complications if we take them out earlier. You know, the pubic symphysis is a little bit shorter. We'll just look at them, see how they look. If they're CRPPs, more than likely we can take them out in the 2 to 3 week mark, but absolutely never before 2 weeks for pelvis patients. And like I said, when they do that staple and wound check, they can do it. Sometimes our providers are okay doing it at the skilled nursing facilities if we, you know where they're going. And then if not, they can come back to the APP clinic on Friday if they're not able to get in with the specific clinic on the day during the week, or if they want to group it together. We get x-rays at 6 weeks. We're going to get AP and Jude for acetabular fractures. And then for pelvic ring fractures, we're going to do, we're going to get AP inlet and outlet imaging if they're a ring. Folks are going to have weight bearing precautions for at least 6 weeks. And then at the 6 week mark, if they're like toe touch from an acetabulum, we'll advance to partial progressive. And that is like a 25%, 50%, 75%. And the therapist will work with them to tell the patient, like, figure out how much that is. Then we're going to follow up again in 3 months and 6 months to get x-rays. If we do an exam under anesthesia, we basically just sedate the patient and we go in and we tweak on their pelvis, and we take x-rays to see if we get any movement, if we get any joint instability, if we can manipulate anything. And if it's positive, then we'll go to the operating room, or we're already in the operating room, rather, we can fix it. But if they don't, then we just manage it non-operatively. They don't need post-mobs because we've already tweaked on their pelvis. And then we get x-rays at 3 weeks, 6 weeks, and 3 months. Traction is a kind of our last option. This is if the fractures are too impacted that we can't get hardware in them, or if the patient is too sick to clear for general surgery, for general anesthesia, excuse me. So if the patient, as you can imagine, is stuck in bed for 6 to 12 weeks. So this comes along with all the complications of breakdown and delirium, skin breakdown, delirium, pulmonary complications, all of these different problems with anyone of any age, but also our geriatric population specifically, much bigger risk with delirium. Unfortunately, those are the folks that are typically not cleared for the anesthesia, or because of other reasons that they're not able to get to the operating room. The good thing about this is that when the time is done, we literally just cut the pin and pull it out. And they don't have to go back to the operating room. They don't have to it's not a big procedure. It's literally like a cut and pull. And then they work with physical therapy. But typically, if these folks have a fracture that is managed with traction, their mobility is likely going to be decreased from their baseline, because it's just such a complicated fracture pattern, typically. If we manage somebody non-operatively, they're still going to have weight-bearing precautions for acetabular fractures. For compression fractures, lateral compression fractures, likely they'll be like weight-bearing is tolerated. But if they're acetabulums, it'll be toe touch or non-weight-bearing. They'll have anterior or posterior precautions, and posterior precautions is the no hip flexion past 90, no adduction past neutral, so they can't cross their legs, they can't bend over at their hips, and we don't want them sitting in chairs more than 90 and bending over. Anterior precautions are a little bit different. We don't want them stepping backward. We don't want any hip extension, no external rotation, and then no crossing. And we actually, with anterior precautions, we like them to sleep on their surgical side. So it's a little bit different, but most common, 9 out of 10 times, you're going to get posterior hip precautions. But it's the same pattern that we're going to get x-rays at the 2 to 3 week mark, because we want to make sure that things have not displaced. And then we're going to get x-rays at 6 weeks and x-rays at 3 months. So their 3 week appointment is not a wound check, it's an x-ray appointment. So that's kind of most of the acetabulum. Moving on to the ring fractures, Young and Burgess is the classification that we use here. There are a couple other ones, like internationally, when I was looking at research articles, they use different classifications, but it's pretty similar with like the 1s, the 2s, and the 3s. Lateral compression it was exactly what it sounds like. It's a lateral compression type force. AP compression is more like a front to back, and vertical shear is like a twisting or a sideways. This is how we categorize 1, 2, and 3. It has to do, this is the Young and Burgess classification that everybody always sees, but I personally like this picture better because I think it's just a little bit more, it's easier to visualize. So APC, anterior posterior compression, are the ones that you don't always have to have a pelvis fracture per se. It's just ligamentous. Most of the time, it's just ligamentous injury. You have compromise of the ligaments of the anterior pubic symphysis in addition to widening of the SI joint. And so you don't necessarily have a fracture, but we still have to stabilize at times. The lateral compression is a very common injury that we see for when people fall, and they have fractures of their superior pubic rami and their inferior pubic rami, occasionally involving the sacrum, because it's, you know, a lateral compression force that it all squishes over to one side. And type 2 and type 3 have to do with different levels of displacement and how much involvement, including like the iliac wing, and if they have any ligamentous instability also. Vertical shear, or like your windswept, is when you have, you know, upward shifting of the pelvis that with like complete fracture of the superior and inferior pubic rami and then dislocation of the SI joint. And the vertical shear, these types of injuries, the vertical shear and the APC, are the ones that we sheet the pelvis for, because we're trying to close down that pelvic space and decrease venous bleeding. And so when you like are looking at a plain film and somebody has widening of the pubic symphysis, the anterior pubic symphysis, that's how we know that we need to sheet the patient. So here's some examples of an LC1 here. So you've got fracture in the superior pubic rami, the inferior pubic rami, and then you've got sacral involvement here. And the way that we fixed this was putting a large screw through and stabilizing that superior pubic rami and then stabilizing the sacrum posteriorly. When we're talking about anatomy with pelvic ring, the back here, this is the posterior pelvic ring. This is the anterior pelvic ring. And so it is, it's easier to visualize with the more of like an outlet view of the pelvis, but you have to stabilize the front and stabilize the back most of the time if you have any instability, because like a circle, if you compromise one part of the circle, the other part of the circle is compromised. I don't know if you can see here, but there's just a couple staples of this is 3 staples. Like it's just a very small incision and just a very small skin incision. Inferior pubic rami fractures, we don't, it's not a weight-bearing portion of the pelvis, and so we never fix those. I should never say never, actually. I mean, sometimes you'll see that like the screws, if you did a plate across the anterior pubic symphysis, some of the screws will reach down and they, you know, secondarily stabilize the inferior pubic rami, but we don't ever just fix inferior pubic rami on their own. Here's an example of a vertical shear injury, and I really picked this picture because it's a good example of the 3D imaging and how this looks pretty messed up with the x-ray. Obviously, your anatomy, your pelvis ring is squished. You've got inferior pubic rami, superior pubic rami, sacral involvement. You've clearly got, you know, a shifting, your iliac wings they do not look equal, but like it looks so different on the 3D CAT scan. And so these CAT scans really help us visualize things so much better. Here's an LC2, which has to do with, you know, different levels of that lateral compression. This is what a really poor CT looks like, in addition to poor, you know, this isn't poor, necessarily poor bone quality as much as it is poor imaging. But you can tell if you look at this screw back here, how we fix this injury. This is an older patient, is geriatric. I forget how old, but these thicker screws is what helps get better grip on that, you know, osteoporotic bone and that bone with the poor bone quality. Those thicker screws, if you look at the difference between that screw and these screws over here, they're a lot thinner. and this is a lot kind of a chunkier screw. And so this helps get better grip that the bigger screws do. So for management, we can treat them operatively or non-operatively. A lateral compression 1 is most often non-op unless it's a pain issue. And so with these type of fractures, they are, if we think it can be managed non-operatively, then we get the patient up and we mobilize them, and then we see how they do pain-wise. Now, the problem with our elderly population is they don't move very fast sometimes. And so people, they don't want to mobilize for like 3 days because they hurt. And so we still don't have a definitive plan until they get up and move, and we look at their imaging to see if anything has shifted or moved. And so that's why sometimes our plans can be a little bit delayed because the patient hasn't got up and mobilized yet. LC2s, LC3s, AP1, 2, 3s are typically managed operatively. And if it's a combination, they're definitely managed operatively. If people have ligamentous compromise, which means widening of the SI joint or widening posteriorly or widening of the anterior pubic symphysis anteriorly, we will sometimes use an X-fix, or we'll use an in-fix if a patient has a large abdominal envelope that we're able to feed the bar through. And I'll show you a picture of that. But the X-fix used to be something that we didn't use for definitive management, and now it is something that we use for definitive management. And so people can heal in these X-fixes for 6 to 12 weeks. Granted, if someone is unstable and we know that they need just to be stabilized temporarily because they can't tolerate a long surgery, we can place an X-fix just to stabilize it and then go back and revise it. But a lot of times nowadays, we are just using X-fixes to fix to definitively manage. When you do an X-fix, both of them stay in place for 6 to 12 weeks. If you have an X-fix, you have external pins. If you have an in-fix, you do not have anything external, and you do not have to do any pin care. An in-fix you can take off at the bedside, and an X-fix has to be taken out in the operating room. Did I say that backwards? Yeah, X-fix at bedside, in-fix in the operating room. This is what they look like. So an in-fix has a smaller connection because all of this is underneath the patient's skin. Now, obviously, they chose to fix this person with an in-fix because if we put a plate across here, we wouldn't be able to reach this part. So we can't plate. We have rarely, but this was not a fracture pattern that they thought that they could get good fixation with a plate that goes all the way across. And so then they stabilize here, which then holds this in place, and then new bone grows. And it's not a perfect, pretty, smooth picture, but it does grow. Over here on the left is an X-fix, and you can see the difference is the big, huge connectors. The big, huge connectors are external, and you can see just by looking at these imaging, if you know what you're looking at, that this is definitely an X-fix and this is definitely an in-fix. But you can't, unless you see the patient, you don't always know unless you know what you're looking at. Sacral fractures, there's U fractures, H fractures, and those are kind of defined by the pattern of, if they're on both sides and then across, transverse. The S4 and S5, although they hurt a lot, or coccyx fractures, they hurt a lot, but we don't do anything about it. It's not a weight-bearing portion of the pelvis, so we just do pressure relief and comfort support. And if we have to fix a sacrum, we can do it through a closed reduction percutaneous fixation. And sometimes we do that just for pain, even if it's not significantly displaced. And if we have a U or an H fracture, then we will work together with our spine teams and do a lumbopelvic fixation, which looks like this. So this is how we do the horizontal screws, and then the spine team do the vertical screws. I pulled up this picture to demonstrate that it's really hard to see sacral fractures on x-ray. Unless they're big and glaring, they're really hard to see. And these are a lot of our patients that go to an outside hospital, they get a pelvis plane film. They say, okay, your pelvis plane film is fine. Go home, come back and see us if you still have pain. And then they come back to their doctor 2 weeks later, I still have pain. We get a CAT scan, and then they have a fracture. And so sacral fractures are super hard unless you know exactly what you're looking for, or if it's a big glaring fracture. So a couple studies that I pulled up, I really wanted to talk about this study because this study actually was at Harborview. And this was conducted by one of our attendings, Dr. Firuzabadi, and it was a review of 156 patients over the age of 65 and involved the most common fracture patterns. And here, looking at the data, most of their injuries were from falls, some from standing, some from ladders, but the majority of them were from falls, which is the most common with our geriatric populations. And most of these folks were community ambulators before they fell. And when they left, 77% had to go to a skilled nursing facility, and 16% of them went home. And when we looked at the average operative age of non-operative patients were 75 and operative patients were 78. So it wasn't like a big difference in operative age significantly, whether they chose to be operative or non-operative. It all had to kind of do with the mechanism or the fracture patterns. But when you compare the operative versus the non-operative, there was a lot more non-operative injuries, and they had the non-operative people had on average more comorbidities, and some of them unfortunately were managed unoperatively because they were too unstable and not medically fit to go to the operating room. The length of stay, 13 and 11 days, and the OR, obviously there's a lot of OR time, and they got more blood transfusions for operative, and it wasn't as pertinent for non-operative. But mortality really is what we're looking at, right? Because we want to do these operations with people. Are we doing something to benefit them, or are we just doing something that is going to cause more harm? And so for folks there, the overall 1-year mortality was 32%, and these are our patients at Harborview. And the folks that, 78.4% of the patients who died were within the first 75 days of injury. And I think that's really important, because even when they leave the hospital, there's still risks. They're still fighting off, things like pneumonia and, UTIs and all of these other things that typically infections and surgical site infections and things like that. This article didn't break down exactly what those folks died from. But it still just shows that even if they get out of the hospital, the battle isn't quite over. There definitely is some data that talks about, blood clots also, and everybody, I think I didn't address this in my post-op slide, I apologize, but everyone who has a pelvis fracture gets DVT prophylaxis, everybody. And some of our population is already anticoagulated, but everybody gets DVT prophylaxis for 6 weeks. And there's a new study out, the Prevent Clot study, which ironically was also written by the investigator who was on this trial, Dr. Firuzabadi, and has shown that aspirin works. It's not better than enoxaparin, but people had about the same amount of DVTs and PEs when they had aspirin versus enoxaparin. So we've started to use aspirin as a shift, because we've kind of extrapolated that data. Although the data was in a younger crowd, we were able to apply that kind of to our orthopedic patients in general. I'm sorry if I'm kind of skipping through this. I'm running out of time. I apologize. But basically, like, the sickest patients don't always get surgery because they can't clear for surgery. Of all the fractures that they looked at in this study, geriatric population was only 14%. And the operative patients did have lower mortality rates, and most people had to go to SNFs, whether they were operative or non-operative. When you look at, this is a pelvis ring study, which I think is really interesting, because when I was looking at data for pelvic ring injuries, most of the studies were abroad, and the mortality rates were a lot higher, like 30%, and they were a lot lower here in the US. And so this was a systematic review of 11 cohort studies, and it was people greater than 65, and they looked at on non-op management, and then if they went operative because they failed non-op management. And the period of how long they waited until from operative to non-operative kind of fluctuated. And one kind of weakness of the study is that it didn't include the fragility index, so it didn't really help us see how sick these patients were kind of at baseline. So 6 of those cohort studies had anterior ring fixation for displacement and pain. They also used EUAs to fix these fractures, and which I think with EUAs, it's really hard to quantify, because how much one surgeon tweaks on an image, or or they get an image, how much one surgeon tweaks on a pelvis versus another surgeon, how much they tweak on a pelvis can be a little bit subjective. And then one study of one of the 84 patients, they had, when they failed non-op, they were operated on, and at the end, when they came back for follow-up, no one had any difference in mobility. So that's really great when you're comparing non-op versus operative. And they definitely cited that osteoporotic bone can be very challenging to fix operatively, and that's why some of these companies are coming up with bigger screws that give more grip. And then when people followed up, when they did their follow-up, if they had malunion, meaning it healed wrong, non-union, it didn't heal, or hardware failure, meaning it broke or moved, then they would transition to operative management. And sometimes that was at like the 3 to 6 month mark. So that also kind of gave our window a little bit more variability of when these people transitioned over. This was a kind of a study that compared, I looked at this because it looked at high energy versus low energy falls. And it was just interesting to me that the majority of the low energy falls, which is like our geriatric population, the fall from standing, that the majority of the pelvic ring fractures were all from low energy. The majority of them females, and they had a very low mortality rate, only 2%. But they didn't give me if that was like a 90-day mortality or a 1 year or what. And most of the mortality attributed to pelvic bleeding. So I thought that was pretty interesting in these low energy falls. In 157 patients, they didn't have a lot of death, which is really fantastic because we see a lot of these. So basically, pelvic fractures are super common, and they affect a lot of folks, but in the geriatric population specifically, they can be really hard to manage given their risk of the complications once they leave the hospital, in addition to, operatively fixing their osteoporotic bone and tolerating these long operations, can be, all part of the risks that go into managing these. When they leave the hospital, you can still have a high mortality, and for ring fractures, they have similar outcomes, whether we manage them operatively or non-operatively. And acetabular repairs are super long cases, and so that contributes to pain, lack of mobility, and prolonged hospital stays, but only by not by a statistically significant amount. So if you ever have any questions about any of these patients, please reach out to me, reach out to any of my other teams. Here's my email, here's my pager. You can Epic chat me, Teams chat me. If it's a pelvis patient, you can always reach out to me. If it's not a pelvis patient, I can help you figure out who you need to talk to and how you need to connect with the team that the patient was managing. And then if you want to send me an evaluation, I would appreciate it. And here's the link to that. I'm going to check in the chat here. All right. How widely available is the how widely available is it? So here at Harborview and at other major trauma centers, the 3D CAT scan is available. It all has to do with the cuts in the CAT scan and whether or not the hospital has the technological capability. It's the same type of CAT scan. It's just like the computer program that allows you to formulate those 3Ds. A lot of times when we get scans from outside hospitals, we're able to reformat those CTs. And so for us at Harborview, it's no problem. At other hospitals, I think they just have to buy the technology, but they have the baseline that we can just add on to, if that makes sense. Would eSIM be useful, or is it ever used acutely post-surgery on patients with more mobility limitations to help improve? eSIM. I don't know the answer to that question because that's not something that we use here about the eSIM being useful. But I'd be happy to look into it and get back to you. It's just not something that we use here, so I don't have a lot of information on that. I would tell us a little bit about the OR. I'd imagine that you need a lot of sterile. Yes, lots and lots of sterile equipment. They unpack pretty much like everything to they get these huge boxes of screws, because you can get screws that are like 2 millimeters, 3 millimeters, 4 millimeters, and they definitely have to have a lot of options and a lot of equipment. We have our own OR. We operate in OR 7, and we operate with our own team, and we will not, these are surgeries that we're not going to start one of these cases at 4 o'clock in the afternoon because of how specialized it is. And we know it's going to take like 4 to 6 hours typically for these complicated cases. And then lastly, are you open to virtual follow-up visits and staple removal for patients returning? So our clinic, we can't do any out-of-state virtual visits anymore from Alaska or from any out-of-state. That got kind of nipped in the bud for when COVID ended. We're not able to do any more virtual visits. Are we open to staple removal at other places? Yes. Or if they have access to Epic, they can put pictures in the chart in the media tab and like shoot us a message and say, hey, can you take a look at this? And we're ready to take out the staples. We are open to that. Ideally, we'd like everybody to come back because it's the safest for continuity of care. But right now, if they're not able to, then we just have them follow up with their PCP or any orthopedic surgeon that they're able to work with in their local area. Robotics, we don't use robotics for pelvis fractures. So I'd imagine not super useful because there's so much, a lot of this, when we get into the operating room, we don't just like cut and place, we have to manipulate the fracture to get it back in alignment. And then we can put screws in the way that we want to. And so we don't use robotics, and I'm just not sure if other places do, to be honest with you. Is awareness of osteoporosis follow-up and RX improving with pelvic for extending focus on the hip, but less on the pelvis, it seems. Awareness of osteoporosis follow. I think that working with you guys has really kind of brought that to the forefront of us of being more tuned in to, osteoporosis management. It definitely is in the more forefront of the literature, in the last 10 years than it was. And so part of the problem is that the medications that we want like to give to people can impair, bone healing and things like that. So we don't always start them initially, but, it is something that definitely is on more of our brain now than it was in the past. And we are very thankful for your guys' recommendations when it comes to managing those types of things.
There was one other question from Mary Zeitner, who has declared that she never wants to have a pelvic fracture after hearing your talk. But she's wondering how long it typically takes an older adult to get back to normal activity and resume recreational activities.
So, I say minimum 3 months, but it also depends on their injury pattern. If you're like an LC1 and whether you're operative or non-operative, after that 6 weeks and your weight bearing is lifted, you can resume whatever activities you want. As we know, our 70-year-olds, some of them are running marathons, some of them are very much not running marathons. And so if you're going to start going back to your yoga practice, it might take a little bit longer, but if you're just getting up and moving and going to the grocery store and doing those things, 3 months is very realistic. If it's a big combined, vertical shear injury, probably 6 months, because you're going to be off your feet for 3 months, completely non-weight bearing bilateral lower extremities. And then you got to work back and get that muscle and that movement back. And it's just harder in our older population to get that back. So if it's a big complex injury, I'd say more like 6 months. The simple ones, more like 3 months.
Great. And there's a comment about some of the literature regarding starting osteoporosis treatment in-house. That is out there. Dr. Ritchie mentioned that. We're at 9 o'clock. So we're gonna wrap up. Thank you so much, Aspen. This has been really helpful to understand pelvic fractures better. I think it'll help us in partnering with your team to take good care of these patients. And we really appreciate that all. We appreciate all you taught us today and all that you do. And certainly for taking the time.
No problem. No problem. It was really great chatting with you. Thank you. And I'm gonna, I know that there's the data on the osteoporosis and the bisphosphonates. I know that there's a barrier as to why we don't start it inpatient, because every time we try to order it, my attendings say no. So I'm going to look more into that because there is a specific reason, and maybe I just misspoke and it's not the reason that I think it is. But I know that our attendings never want us to start them initially. So either way, yes, thank you, Kay. I would really appreciate that. That would be great. Email me, please.
Very great. And everyone, don't forget to click on the evaluation form to give Aspen some really great
Getting booted
feedback.
from my room, so I'm moseying out of the way.
Fantastic. All right. Well, thank you, everyone. Thank you, Aspen.
Thank
Have
you
a good
so much. Have a
weekend.
wonderful day, guys. Yes, please send me those resources, Kay. I would really appreciate that.